My name is Anissa Mitchell, and I'm with PMD Alliance, and I am excited to be joining you in a conversation today. We're going to be talking about anxiety and Parkinson's, but some specific aspects of that based off some work that our two speakers have written a paper on. We're going to be talking about something called anxious fluctuators today. And with us today is our two speakers, Dr. Zoltan Mari. He's a movement disorder specialist. He's with the Ruvo Family Chair. He's the Ruvo Family Chair and Director of the Parkinson's Disease and Movement Disorders Program at the Cleveland Clinic, Lou Ruvo Center for Brain Health in Las Vegas. He's also an adjunct associate professor of neurology at Johns Hopkins University. So we're happy to have Dr. Mari with us. And we also have Dr. Gregory Pontone. He is an associate professor in the Department of Psychiatry at Johns Hopkins University School of Medicine. He's also an attending psychiatrist in their geriatric and neuropsychology division and is director of the Johns Hopkins Parkinson's Disease Neuropsychiatric Clinic. So we have two experts in the field addressing this subject matter, one a movement disorder specialist and one in psychiatry and neuropsychiatry that have both overlapping and interesting perspectives in this field. So we want to invite them to this conversation, and I want to kick off, and I don't know which one of you might want to answer this question first, but we want to know, we talk about depression in Parkinson's and anxiety in Parkinson's, and, you know, really we're just starting to, in the last few years, really surface how much these symptoms play a part in a person's life and their quality of life. So how common is anxiety in Parkinson's?
Yeah, I'll take that one. So probably the best estimate is that at least 30% or a third of people who suffer from Parkinson's disease will have a diagnosable anxiety condition, not just symptoms, but actually a sort of condition that usually requires treatment. And that's significantly higher than people who don't have Parkinson's. And so that's why we think the disease contributes to the risk. You know, whatever's changing in addition to the movement symptoms, it's increasing people's experience of anxiety.
Awesome. I didn't know if anything, do you want to add to that, Dr. Mari?
Yes, I agree that when we talk about the 30%, it is important to note that this is a very conservative reference, a very highly rigorous methodology that was used to establish that number. And when Dr. Pontone says that this has to be a formally diagnosed anxiety syndrome, that is kind of a official and formal diagnostic criteria to be met. Patients who have some form of anxiety symptoms and experience some kind of anxiety would be much higher than that number. And so when we talk about these rates and prevalence, we have to also be clear what we are measuring and what criteria and methods were used to establish those numbers. But due to the fact that anxiety is relatively common in the general population, it has taken a relatively long time for us scientists and epidemiologists to actually establish a link that the connection exists, and it is specifically Parkinson's disease and the Parkinson's disease pathology, the process that causes Parkinson's disease motor symptoms is clearly and statistically significantly is associated with anxiety. So it's not just that it's a common condition and we just happen to see it in Parkinson's disease as well. No, it is Parkinson's disease that is why there is a greater prevalence of anxiety in PD patients.
And it's not because they have Parkinson's, you know, that they're anxious. It's the disease that's caused the anxiety. And can you talk about how's this occur in terms of depression? Can someone, I know it's often said people will have depression and anxiety, but can someone experience anxiety independent of depression? Can that be its own issue?
Yes. So most often, if you have depression, you'll also have some degree of anxiety. But it is also possible to have anxiety with a perfectly reasonably good mood. And it might have something to do with the brain circuitry that's involved. So usually when someone has a mood disorder like depression, the anxiety is part of that mood dysregulation. Whereas there's other types of anxiety. In fact, one of the types we're going to talk about today that might be a completely different network in the brain and, influenced by different factors. And so in this case, we're going to talk a little bit about dopamine driven anxiety or dopamine change driven anxiety. And then there's also a model for anxiety that is more based on cognitive change rather than mood change. But traditionally, just as you're saying, the sort of what we call affective or mood driven anxiety is the one that we talk about most often being associated with the depression.
So we are getting some questions. We don't want to hold them because I think they're going to go with what you're going to discuss. So I would love for us to go ahead and talk a little bit about some of the variety of manifestations of anxiety, the subtypes that can occur, beyond a typical expression. So can you start off first by explaining some of the subtypes that you mentioned, just started to mention, and, what those are and how they might manifest?
Sure. I'll talk about the ones that are the more general psychiatric ones, and then I'll let Dr. Mari sort of talk about the ones that are more specific, the Parkinson's. In general, whether you have Parkinson's or not, probably the 2 or 3 biggest anxiety disorders are what we call generalized anxiety, which is sort of that free-floating, ubiquitous worry that you have about even mundane things. You're worried about day-to-day things and you can't let go. And they just keep spinning round and round in your head to the point where you always feel keyed up, tense, or on edge. And that might even make you irritable. It might interfere with sleep. It might affect your appetite. It might cause headaches and other physical symptoms. That's a very common type of anxiety. We see that in people without Parkinson's, and it's also one of the most common types of anxiety we see in Parkinson's. The other type of common anxiety disorder, both with and without Parkinson's, is what we call panic disorder. And instead of being sort of a chronic state of worry and high tension, it's more episodic. It's typically, you could be perfectly fine and sometimes without any trigger. And frankly, that absence of trigger is what makes it so scary because it happens out of the blue. You experience a very sudden onset of high panic level, emergency level anxiety that can last for 5, 10, 20 minutes or more, where you have a lot of autonomic nervous system arousal, like the fight and flight response. So not only are you worried and afraid, but you're literally, your heart's racing, maybe you're having stomach cramps, you're tremoring and shaking. And this is so severe that literally then even after the episode resolves, we have people who live in fear of having another one and then maybe won't leave their house for fear of having another one. And that's when the panic disorder becomes associated with what we call agoraphobia, fear of being in open space because you think you can't find sanctuary if you're outside of a safe place. And so people then become very reclusive, even though it's an episodic disease. And we found that not only is that one of the more likely ones in non-Parkinson's populations, it's also one of the most common types of anxiety in Parkinson's. And then the other one that we see a lot is what's called social phobia. And social phobia is sort of a fear of doing almost anything in the view of the public or in the view of other people. And, most notably, people think of, a fear of public speaking, but it's not just speaking on a stage. There are literally people who have such a social anxiety that even speaking in front of 2 or 3 people is intimidating. And so they'll often avoid or withdraw from social engagement. The other one that we don't talk about much is there are people who are so fearful that they won't eat in public. And I think Parkinson's, for instance, contributes to that because they might already be a little hesitant because their motor function isn't so good and maybe they're a little messier. And all this sort of snowballs into social isolation and withdrawal. Using public restrooms can be another facet of the social phobia. And, certainly all of these things can be problematic, but there's other types of anxiety, but these are probably the big three that we talk about the most that aren't necessarily specific to Parkinson's.
I had a gentleman that I had worked with a few years ago when I used to run support groups in Orlando. And he had exactly what you just described. He would get such an anxiety. He'd want to come to a group and he would get so anxious about the concept of going. He wanted to go, but he was fighting against himself because he would have, start getting so anxious about going that he would drive there, turn around and leave. Or if he would get somewhere, he would always position himself that he could have a quick exit. And so he developed this severe social phobia of even going out, and he ended up isolating himself. And he would say, I'm isolating myself, and I can tell that it's having a significant impact on my health and well-being, but I can't overcome the anxiety that I'm dealing with. It's so overwhelming, and I can't seem to find anyone that understands it enough to treat it, because I've tried multiple things and nothing's helping. So everything seems to trigger it. So this sounds like the very thing that you just described. And someone asked, can anxiety trigger autonomic dysfunction? Because you mentioned that they get so anxious that they have that autonomic function disruption related to temperature control. So are the chills and heat causing the anxiety, or is the anxiety causing or making the chills and heat worse? That's a good question.
Yeah, absolutely.
That's a great question, and I'm so glad that you noted that there are all these questions in the chat, and they are very good questions. And as much as we already prepared with a number of questions, I do like the idea of taking some of these audience questions and especially if they are relating to our topics closely. And so one question before I get to the autonomic one was about when the anxiety would develop. Somebody mentioned the 10th year, and as much as we discuss these specific syndromes and types of anxiety from the diagnostic and classification standpoint, it is also a very important question as to, is there a difference between anxiety that starts actually before motor symptoms of Parkinson's first appear in the first year or beyond that? What is the rhyme and reason to that? And you can have anxiety in any one of those points. There's one study that Greg conducted where you see a very clear increase in the incidence around Parkinson's disease start, but it can present later, 10 years into the disease. And we don't know why that is, but there is some theory to implicate that the pathology that's ongoing in the brain from the Parkinson's and going and propagating in various parts of the brain, obviously, first and foremost, the nigrostriatal dopamine system will be part of that process because that is responsible for the cardinal motor symptoms, but other networks are also going to be attacked, and when and how varies from one person to another. And also, because we are all different, our compensation mechanisms will also be very variable, and some people can have stronger, naturally in place compensation mechanisms for why they don't experience anxiety clinically manifest form early on, but they will later on as the disease sort of progresses. Now, coming back to the question about the temperature control and dysautonomia, to my knowledge, I don't believe that there's a very clear trigger in a molecular manner between autonomic symptoms and anxiety per se. But when you have anxiety, there are many different ways that you're going to experience that. And one of them is relating to your sense of heat. So this is not uncommon that you would experience that. And which one comes first? I let Greg sort of discuss that, but I don't believe that there's a direct connection that way. Having said that, dysautonomia and autonomic issues in Parkinson's disease represent a very important non-motor symptom area besides the neuropsychiatric symptoms.
No, I think what Zoltan said is absolutely on point. So one of the things is that both of these anxiety and autonomic dysfunction occur in Parkinson's. So up to 70% of people who suffer from Parkinson's will also have autonomic nervous system dysfunction, everything from blood pressure dysregulation to excessive sweating to hot flashes and whatnot. And so just as Zoltan said, which comes first or which is experienced as anxiety when it's actually autonomic dysfunction is in dispute. And so what I can tell you, I'll tell you a little story. First, I'll tell you the story within Parkinson's, and then I'll tell you it globally about the connection between autonomic arousal or dysfunction and the experience of anxiety. The first is, there was a study almost 25 years ago now by Berrios, Berrios, and his group. They did a study of autonomic dysfunction in Parkinson's and its association with anxiety. And they definitely thought that having autonomic dysfunction, whether it's the sweating or the chills or the heart palpitations or blood pressure things, was reported and experienced as anxiety by some people. And now whether or not that's the same thing as, idiopathic garden variety anxiety or just mimicking it, you feel the arousal, so you feel anxious, was unclear because they couldn't really measure anything biologically other than, the blood pressure and symptoms. And in the same way, I had a colleague at Johns Hopkins, Rudolf Hohencerich, who spent his entire career studying how the autonomic nervous system might contribute to anybody's experience of anxiety. And he did really fancy tests, like he would do galvanic skin response, so how your skin conducted electricity and would sweat, when you get anxious, how your palms get sweaty. And he'd measure all these things to see if they correlated with the reported experience of anxiety, meaning that maybe it's the nervous system that's behind, is the basis for some of these anxiety syndromes, maybe panic, for instance. And ultimately, after 4 decades of research, he didn't have any conclusive findings. So in a very long-winded way, I just said what Zoltan said in 2 sentences. While we do think there's some sort of overlap, we can't with any certainty say that one causes the other.
All right, so in your paper, you talked about atypical anxiety disorders that don't meet the DSM-5 criteria. There is common, and you're talking about, there's a lot of expressions of this. So can you talk about how some of this, and I know people are starting to ask, how is this related to on-off fluctuations? Can taking more medication help with this? And I know that kind of leads into where we're going with this particular terminology of anxious fluctuators.
It's the perfect segue. So it's actually how Zoltan and I came to the idea to do this study in the first place. Is Zoltan and I were sitting, probably at one of our meetings, and we said, okay, if this is all the anxiety that our patients who have Parkinson's disease suffer from, and we know that this much of it is what we can find in the normal, diagnostic and statistical manual of psychiatry that's already been described for hundreds of years. There's this other piece, maybe a third of cases, that don't fit these diagnostic codes. They don't have this criteria. They're different. They look different. They look like they're provoked by different things in the environment or different situations. How can we figure out what these are so that we can treat them better? And that's really where the idea of this study came from. And remember, I'm a psychiatrist and Zoltan's a neurologist. And so he said, I'm giving these people medicines. And, even when I try my best, sometimes they go up and down. They take the medicine and they get relief, but then they wear off and then the symptoms come back. Could it be that? And then I'll let Zoltan kind of describe from there how we came to the idea.
Yes, so it is a very interesting observation. We came from, at least I came from the assumption that, this is simple. If your dopamine is low, then you're going to be anxious because you're off, and that's unpleasant, and that is a trigger. And so all we have to do is get the therapy optimized. Let it be DBS, let it be Duopa, let it be oral medications. Once we get a relatively good and stable, even dopamine receptor engagement with whatever therapy modalities we have, we will fix the problem. And that's a very simplistic approach, which obviously turned out to be not working for everyone. And before I move on to the ones that this doesn't seem to work with, I should also say that in a lot of patients, it does do the job. And a great deal of our anxiety is in fact related to the dopamine levels or the motor fluctuations. But it's not as simple. So first of all, besides the dopamine level, there's also such a thing as the dynamic process of the dopamine receptor engagement. Now, if there's a steady state, and in the physiological normal brain, we believe that the dopamine level in the synaptic cleft should be very steady. There shouldn't be rapid ups and downs in the dopamine level. So as far as the dopamine engaging those postsynaptic dopamine receptors, there shouldn't be a lot of dynamism in there. It should be a slowly moving process, and that's how our brains are made physiologically. Those postsynaptic structures, the signaling beyond just the dopamine receptor, they're not able to handle big swings in the receptor engagement. That's just not how we developed. So when you subject them to those conditions that they are not made to handle, all bets are off. And how it is played out in each individual patient will vary. And that was part of the reason why we empirically noticed that it's not as simple. I mean, I'm seeing this patient clearly with a high dopamine. Why are they anxious? Or they have a low dopamine and then the anxiety improves. That doesn't make any sense. Or maybe they are dyskinetic even, which is a motor symptom usually seen with peak amounts of dopamine, but then we are not looking at a peak amount of dopamine, and they are displaying these symptoms as if they were. What's going on? Well, one of the things that we think may be going on is, as much as the receptor occupation and the level of dopamine is a factor in some of these symptoms, so is how the change is happening. So the delta, the speed and rapidity of engaging the receptors and sort of on the upswing of that process, as well as the downswing and the micro fluctuations. It's one thing that somebody's levodopa starts getting into their bloodstream and eventually through the blood-brain barrier that results in increasing dopamine levels ultimately. But that is also affected by a number of local factors within the tissue for why there could be a micro fluctuation of the dopamine level. There could be a drop in that overall global increase process that takes place over minutes and hours. For seconds and minutes, there could be the opposite, and that could throw things off completely. So the bottom line is that we can't mechanistically explain everything just by where you are with the dopamine. Having said that, if we can replicate what is physiological, that there is no ups and downs at all, we could take care of many of these problems. But because we can't do that, even with Duopa, even with anything that we have right now, we just cannot produce or reproduce the physiological, almost constant, perfectly steady dopamine in the brain. We have to deal with the phenomena that result from that imperfection and explain them as best as we can. And besides just making sure that the dopamine level is as steady as we can make it, we also have to understand some of these anxiety and other symptoms that result anyway, and they are not just simply from the off, but it's more complex than that, and so that opens up for the need for other treatment modalities just than simply just fixing the dopamine.
So, and I do want to ask in a little bit about how to approach treatment for this, but in the paper, you talked about this potentially being another subtype of Parkinson's. And I know people are always trying to identify, because, you know, it is such a heterogeneous disease. Everybody's experience is different. You know, like someone who has a tremor, the next person doesn't have a tremor. Some has more rigidity, more postural and gait instability. So how does this fit in that? Because I don't know that and you can tell us, does that really even impact how treatment is approached? But, you know, just for people to understand what's going on and be able to articulate it, because in the case, going back to the gentleman that I referenced earlier, who, you know, he didn't have a lot of motor symptoms, but he had a lot of the non-motor symptoms, and those obviously fluctuate, and we don't necessarily talk about that as, or it's easily defined as motor fluctuations, but no one was able to ever really determine what was going on with him. And when I read your paper and was, you know, preparing for this talk, he was the first thing that popped into my head, especially if you gave your example, Dr. Pontone. So can you talk about that? Can you talk about whether this is a subtype and what that might look like?
Absolutely. When we do think it's a subtype, and I think that's sort of what Zoltan was expressing, is that, you know, he's been doing the management of Parkinson's medications for decades, and he's very good at it. And he would optimize, you know, some of these people who, even when the pattern looked like it was fluctuating, he would optimize the medication regimen to the point where we were confident that they now had the opportunity for steady dopamine levels, and yet their symptoms were still fluctuating, meaning that it's an idiosyncratic, you know, individual basis that these people somehow, like a diabetic, right? You give me 100 grams of sugar, you give a diabetic 100 milligrams of sugar, and we're going to handle it two different ways, right? The diabetic's going to be up and down, hyperglycemic, hypoglycemic, and all over the place, whereas I'm going to eat it up and ask for another candy bar. So far until I get diabetes. But the point is, that's what Zoltan's saying is, you know, he treats all these people the best he can. And some of them, no matter whether you do your best and everything's perfect, they're still very brittle. They're still all up and down. And that's got to be some sort of individual biologic difference. And our point is, we need to be able to recognize these people, not only so they don't have the anxiety, but all the other complications that come with therapy. We need to be able to pick these people out. And one of the things, to your point about the gentleman you mentioned, one of the things that marks these people clinically, and until we have a biomarker, is that they are more anxious to begin with. So people with higher anxiety to begin with are more likely to have these anxious fluctuations. And the other really interesting thing is, it's not that they're not responding well to dopamine. They respond, if anything, they respond better. So if they're really off and they're frozen and you give them a big dose of dopamine, they respond robustly. Their symptoms get really much better, but then they crash again. And so it's that brittleness. So it's not that they're not taking the dopamine and using it. It's just that they're from the ceiling to the floor, from the ceiling to the floor, erratic all over the place. And we need to understand that difference. And we definitely think it's a subtype. Now, here's what's interesting. It doesn't necessarily have to be a subtype of Parkinson's, right? It could be a subtype of another gene that handles the metabolism of the levodopa precursors, or like Zoltan was saying, the tissue, has something to do with tissue distribution of any medication. And so until we figure that out, we're going to miss some of these people. So like Zoltan said, he says some of the people, you come in and you reorganize their dopamine and their anxiety goes away. Those probably aren't the ones we're talking about. Those are probably the ones who are just not on ideal dopamine. The ones we're talking about are the ones, even when an expert like Zoltan comes in and fixes their medication perfectly, they're still anxious and all over the place.
And I think the significance of this in the practical sense is also that before this study, we didn't have any firm evidence to fall back on to know this for sure. And it is natural prescriber or provider behavior or psychology that if something doesn't seem to make sense to you on the surface, something is wrong with the patient's reporting, it's unreliable, they are probably not compliant. So there has been the issue with some of the doctors who see Parkinson patients, with the patients reporting anxiety and other symptoms that just don't make sense. And so that sort of wording of not making sense comes from the assumption like, all right, are you dyskinetic when it's no? So it's just nonsense. It doesn't make any sense. Well, it doesn't make any sense if you rely on the assumption that all we need to do is fixing the dopamine therapy, the dopamine replacement therapy. And if that's done perfectly, then there should be no problems left. If the patient is reporting some problems left, it just doesn't add up. So many doctors would be looking for sort of reports and descriptors of on and off from the motor perspective. And then they were trying to understand how the non-motor symptoms such as anxiety, panic, or depression might be correlating with that, because their understanding was trying to fit that. If you have a hammer, everything looks like a nail. So that was their sort of thinking. And then they would dismiss patients who reported things that didn't fit that model or didn't fit that algorithm that they only knew. And now with this paper, we have something to present that, look, this is a very high quality paper, 200 patients, methodologically extremely rigorous. And this is as strong as an evidence that there can be to show that it's not that simple. Your algorithm, that as long as you fix your motor symptoms, you fix the anxiety as well, just doesn't fit. It just doesn't work that way. There will be patients who are genuinely not fitting that formula, and that exists. And again, for reasons like Greg mentioned, that we don't quite understand fully, but it is a very legitimate and existing type or phenotype or endophenotype, whichever word you want to use for that. And we need to deal with it and accept that this exists. And of course, we still need to fix the dopamine system as best as we can. That goes without saying, and we will always do that when there's an opportunity or where we see that needs to be done. But even if it's done, there is a legitimate population, maybe a minority of patients with anxiety, who will not just simply be fixed by fixing everything that they need from the motor standpoint with the dopamine therapies.
Yeah, I just want to add one thing and emphasize something that Zoltan said, because I think this is a common frustration for people with Parkinson's. Exactly as he said, they're complaining that they're feeling anxious, and then they see their neurologist and they hear, what, you're not dyskinetic and you're still moving well, but that doesn't make sense. And then everybody's frustrated. The clinician says, I don't understand what's going on. The patient feels like they haven't been heard, and yet they're very anxious and it's been missed. And I think that's what we're hoping this paper will bring to light, is all these people who've been suffering with no explanation. Now we're going to help not only the people with Parkinson's better recognize it, but the physicians, and give them a better way to handle it.
Yeah, I mean, as you were sitting here describing this, it made me think how you're giving voice to people who have been saying, I don't care what you're saying, this is my experience. In fact, earlier, Donna had commented, I've had anxiety lifelong, but when my PD started, my anxiety was different. And so, it is a different experience. And that's also another, I guess that leads into another question. Like, we, have heard that anxiety and depression can be one of the early prodromal symptoms. And so if this is the case, then those who maybe have this subtype, does it actually then morph into a different expression? I mean, it sounds like what you're describing is that's a possibility.
Yeah, so Donna, I actually love that we have a concrete example where Donna's telling us that she's had lifelong anxiety, but that when she had Parkinson's, its manifestation, the way she experienced it, changed after she was diagnosed, and presumably after she started taking Parkinson's medications. This is actually classic example of what we think is happening. So it turns out in this study that we're talking about today, the one thing that predicted people having these anxious fluctuations was a prior history and a family history of anxiety. And so this might be some genetic variable that increases your risk, whether you have Parkinson's or not, of anxiety, but also of having this type of fluctuation. And so we know with high confidence from many, many studies that people who have anxiety earlier in life are almost twice as likely to develop Parkinson's later in life. And now this study shows that not only are they more likely to get Parkinson's, when they have Parkinson's, they're more likely to experience this atypical fluctuating anxiety.
And I think one very interesting aspect that Greg mentioned was how, when we are thinking about types and we are classifying, you mentioned tremor predominant, PIGD, and many other ways that we can subtype Parkinson's disease. Keep in mind that it is not necessarily just the Parkinson's disease itself, the pathological process that causes Parkinson's disease itself, that may be responsible for the heterogeneity that we see among our patients. It could be that they are just different brains, genetically different brains. And even if the same exact identical pathological process hits those brains, it's not the pathological process that's different, but what it hits is different. And that's could be a reason why it will manifest and look different. One example that sometimes given to demonstrate that point is how young onset Parkinson is different from old onset. And it probably is both, because oftentimes very young onset will have some genetic mutation, and so that could be a different pathological process or different Parkinson actually. But even if just the same Parkinson hits a 30-year-old versus it hits a 70-year-old, that is a different brain. And that is what's oftentimes used why seemingly in a young onset process, it's so much slower progressive. What you lose over the next 10 years when you're 30 and you have Parkinson's disease, at 40, you are probably still working and you are very capable. The Parkinson in that 10 years is probably going to have very little impact, versus 70 to 80, it would be expected to have a major impact. And that's because the young brain has so much more power and ability to compensate. And even the underlying process is the same, it will look different. And so I just wanted to put that in, that when we classify and trying to type things, it is not necessarily the disease itself that's different, but what other factors and comorbidities and age and many other factors that could play into it, why it will end up looking different.
So I know there's a few questions related to this, but is there any correlation to this anxiety and any changes in cognition or potential changes in cognition?
Yeah, in the study we're talking about today, we had a very restricted cognitive battery. We really only tested executive domain cognitive function because we thought that was the one that would most likely be associated with anxiety. And so just to give you an idea of how we hypothesize this might be the case, when you have anxiety, you tend to ruminate, go over things again and again in a circular way, right? You say, for instance, a very common one is about an event. You have someone who says, I'm going to travel, I'm taking a plane, and they start to worry. What if I get to the parking lot and I can't find a parking space? And then the shuttle, I'll miss the shuttle, and then I'll be late. And what if I have to go to the bathroom? Where are the bathrooms? And I don't move very well. And the more anxious I am, the slower I move. And what if I set off the security detector because of my DBS, and right around and around. And most of the time, if you do that a couple times, you can reassure yourself and relax a little bit, right? Because you've gone through your worries and you sort of put them to, you reassure yourself. When you have executive dysfunction, you can't successfully reassure yourself. And so you just keep looping and looping and looping and repeating without moving forward in the process of reassurance. And so that was our hypothesis. I will tell you that other people have looked at this too, using different executive domain tests. And although it's very intuitively appealing that executive domain dysfunction could be, it hasn't consistently shown to be the case across studies. And for instance, there was a study done by Nadika Diskanyaka in Australia, one of our collaborators, and she found that memory was associated, poor memory was associated with anxiety. And so I think the best we can tell you is that we all think that cognition can generate or worsen anxiety, but we can't specifically say what type of cognitive impairment might be the culprit, and it might be more than one.
And again, that comes down to the methods that you use. And Nadika's study, I think, is very well done. And one of the thoughts they had was that it's the working memory that it could be at play. That vicious cycle that Greg was describing relates to how much you can keep in your immediate working memory. You can reassure yourself by simply going through all of these possibilities, and since it's still in your working memory, you check it off. And if you don't have it in the working memory, it's out, then you keep going back to that, even though you checked it off just seconds ago. But this becomes a loop, becomes an endless cycle, because you keep dropping these things out of your working memory, even if you just checked them off a second ago. And so that's how the working memory could be a trigger for anxiety, or the lack of working memory, and it ties to executive function this way.
So I do want to go back to maybe a little more of the experience. So one person made it or stated a question, and person seconded it. So this person said, I seem to have physical anxiety symptoms even though my mood is stable and happy. Is that common?
Absolutely. And I think it sort of gets to the point of what is anxiety. So, what we call anxiety, I think you can have the experience of anxiety for many reasons. So is my question that I always sort of ask when this question comes up, because I think this is really maybe one of the most important questions about anxiety, is when a bear chases you and you're anxious or scared, is that biologically different than the anxiety you have when you have a big test that determines your entire semester grade? Is that literally what your body experiences, the chemical changes? Is it any different, whether it's a bear or a big test, right? It feels the same, right? You're sweaty, your heart's pounding, you can't sleep, right? Whatever. Is it any different? And that's really the fundamental question. And so when people say, there's times with my Parkinson symptoms where I feel really tense, and maybe it's because I'm at the end of my dosing cycle and I feel all the same ways I do when I'm anxious. Is that the same as anxiety, or is it different, and does it matter, right? And more importantly, and this is the question Zoltan and I asked, will it respond to the same treatment? How do we best treat it? Do we use dopamine, or do we use a mood drug, which are completely different compounds? And I think
somebody did ask about SSRI specifically in the chat. I saw that.
Yeah, and I do think that's kind of the next part of the conversation is, okay, so if someone is experiencing this, regardless of their fluctuations, what do we do?
Yeah, so it's funny. We've been, since the publication of this paper, we are continuing to publish from this data set. And so with that, we have found in preliminary analysis, and if this is confirmed, hopefully you'll see it in print, what we found is that it's probably, just as Zoltan said at the very beginning, more complicated than we say in explaining it. We're talking just about it's either dopamine or serotonin, SSRI, selective serotonin reuptake, antidepressant drugs. Both can be helpful. And, in this case, we do think that this fluctuation associated anxiety is mostly determined by dopamine levels, right? Or a brittleness of response to dopamine level that happens at the individual level rather than the absolute level of dopamine you give them, right? Just like Zoltan said, you can do it perfectly and get different, results may vary. So you give these people as good a treatment as anybody else, but these people don't benefit as much. And in those cases, what our secondary analysis appear to show is that if you treat people who are having fluctuation associated anxiety with an SSRI, it seems to mitigate the fluctuation in anxiety. It seems to dampen the experience of anxiety, even though we think it's primarily driven by dopamine. And so if our analysis holds up, that would mean that in addition to doing better with the dopamine, having the serotonin modulator on board could help.
And I would like to add, and I hope nobody considers this to be a biased opinion, but for full disclosure, I have some family connection to clinical mental health counseling, and I know that Greg trained a great such therapist back at Hopkins. So in addition to pharmacology, and in addition to dopaminergic and serotonergic fixes, I would like to emphasize that sometimes non-pharmacologic interventions can also be helpful. And you probably all are familiar with physical therapy, occupational therapy, speech therapy, but there's also mental health therapy and clinical mental health therapy, talk therapy, cognitive behavioral therapy, biofeedback. There are many variants and versions and ways that could be delivered, but generally speaking, mental health therapy could also be part of the management, and I can't see any situation where that wouldn't help. You know, I mean, atypical, typical. In the end, you have a problem, you have an impairment, and I think having a good therapist who understands Parkinson's, who and Linda was, I think, co-author in one of our papers, the consensus paper anyway, somebody who understands these issues well and can individualize and customize the approach to your needs and your situation tremendously can add to whatever we can accomplish with pharmacotherapies.
And I'm so glad that you brought that up, because that was going to be one of my questions, you know, how much that could contribute to the treatment with that cognitive behavior therapy, any kind of talk therapy support, and making sure people are staying engaged. You know, and with the gentleman I referenced before, and I just keep referencing him because he's literally the example. Before we knew what was going on, I remember him and was thinking he's like the example. You know, even he was in counseling and it did help, but he really, it impacted him, because that vicious cycle you were seeing of isolation, and that isolation making him worse in so many other ways. So being able to engage in that therapy is helpful. Now, there's been some questions earlier about other forms of treatment outside of therapy and medications, such as, is there a role for cannabis for managing anxiety? And it probably hasn't been rigorously studied, but to your knowledge, is that something of benefit?
So I'll talk broadly about any psychedelic medication. So as you know, here at Johns Hopkins, we probably have one of the biggest psychedelic therapy programs, whether it's, you know, marijuana or ketamine or psilocybin or LSD. And we've been doing it for probably 40 years now with Roland Griffith's lab. And so here's what I would say. First of all, exactly as you've said, there hasn't been a rigorous study in Parkinson's specifically yet, right? There's a few studies that are underway. I would say that at this point, until we have that sort of data, I would proceed with caution, because I can tell you from our other studies in non-Parkinson's populations that you're equally likely to trigger not only anxiety and paranoia with some of these psychedelic compounds, but also maybe psychosis. And so we would say lead with caution. That said, I think both Zoltan and I can probably tell you anecdotal stories of several of our patients who've tried marijuana or cannabinoid compounds with good effect, you know, both for sleep and for anxiety reduction. I've even had some patients tell me it helps with dyskinesia, but I think until we have formal studies, I wouldn't be able to give you any clear guidance in their absence.
Yes, and I just wanted to say that I have a conflict in this area too, because I am advisor to GB Sciences, which is one of the companies that do not commercially sell any cannabis products, but they are conducting research in understanding what in the cannabis entourage is. They call it entourage because there are so many different individual pharmacological compounds in each of these. They will do what, and so that actually is one limitation as to, patients ask, okay, will this help me? And, I have students rotating with me. I tell them in the beginning of the day that just count the number of patients who will not ask about cannabis. And so it is very popular and very common question, but then help with what? And just like Greg mentioned, there are some evidence that it could be helpful with dyskinesias, levodopa-induced dyskinesias. You can just YouTube it and look for it, and there are all these videos of patients with grade 3 severe levodopa-induced dyskinesia smoking a joint and completely becoming calm. And patients bring that to me and like, don't you see how much it works? And I say, that's a single case. This dyskinesias could have stopped for whatever reason. We don't know, because it could have been just that the dopamine level dropped at the same time and the dyskinesias go away. It's not a controlled study. Is it good for anxiety? Is it good for sleep? What is it good for? So those questions need to be further evaluated. Now, having said that, if a patient comes to me and asks me, oh, my tremor is so much better with this thing, I will not tell them that, oh, get off of that. There is not enough evidence. And the only thing I cannot say is what to try for what problem and how much and in what. It's not like a medical prescription where I give it 3 times a day, this dose. So I cannot give any advice to anyone as to how much to take, what kind of product to take, but patients talk to one another and word of mouth. A lot of patients try things on their own. I generally don't stop them from that. And if something works, with my blessing. But again, the devil is in the details, and we cannot really be specific as to what to try or where to try. We are generally permissive for those who report benefit, but we don't encourage just trying so that perhaps it will work. Talking about the devil is in the details. Somebody mentioned that maybe therapy didn't work for them, and I would like to say that it happens with physical therapy as well. It happens with occupational therapy. When a movement disorder specialist or a movement disorder neuropsychiatrist like Dr. Pontone and I would recommend a certain therapy, that's because you have a clinical presentation and a phenotype or type of problems which makes it likely that those therapies will help you. And if they don't, it could be the therapist. And I just wanted to say that it is very common that patients come to me and say, well, physical therapy, I don't want to do that. I tried it, it didn't work. And then I'm like, why did it not work? What did they exactly do? And that's how I mentioned the devil in the details, because if it's done right, it will work and it should work. And the same is true for mental health therapists. You want to find somebody in psychology today or otherwise who actually understands Parkinson's and has experience with Parkinson's. That can make a big difference.
Yeah, and I would say there's even an old saying about what Zoltan just mentioned about, trying therapy and whether it works or not. They always say, how many psychiatrists does it take to change a light bulb? And it's just one, but the light bulb really has to want to change. And so I think you have to look, like you said, at the therapist and the light bulb and try different fits.
So there's one question that I had that I don't know that we've really talked about and might be a good for the last one. So having maybe this subtype of anxiety, does that predispose them towards any other complex clusters of non-motor symptoms? Because as we said, those can be very hard to manage and aren't necessarily as easy to identify. And I'm talking things like, cloudiness of thought, pain, abdominal discomfort, some of those kind of symptoms.
Yeah. So, we, because we started with this focus on anxiety, I think, what you're mentioning is a very important detail. We think this fluctuation state is much broader than just a fluctuation in anxiety. It's absolutely, our data showed that the people were more likely at the same time they were experiencing anxiety to experience mental cloudiness, a change in balance, motor disability, a greater difficulty doing activities of daily living, abdominal discomfort in some. And so it very likely is a cluster of symptoms that change very brittly from the off to on dopamine state. Again, hopefully the ideal would be that we find some sort of blood test or other what we call biomarker that would help us identify these people so that we could give them the specialized treatment, not only for the anxiety, but for all the other symptoms that seem to go up and down during this state.
Awesome. Well, we're getting towards the end of our conversation today, and this has been fantastic. I'm trying to look through here to see if there's any last questions that we want to make sure that we hit. And we did have someone, I know we've talked about medications, and I think we mentioned DBS maybe in brief. So one person was asking about whether their DBS can help with anxiety and stress. So if it's managing some of those things, is there that potential?
Yeah, Zoltan, has done this for many years, but I'll comment on the anxiety angle. Certainly to the extent that it sort of levels, and provides more consistent motor function and fewer fluctuations. In fact, one of the indications for getting deep brain stimulation therapy is that you're experiencing a high level of motor fluctuations. That's one of the criteria. And so to the extent that the fluctuations are provoking anxiety, it can absolutely, for some people, have a tremendous benefit for their anxiety and other symptoms. Now, that said, this gets back to our phenotype. Is this a subtype of Parkinson's that even when you have nearly ideal motor function, the anxiety can still fluctuate? Absolutely. In which case then, things like the SSRIs, getting those on board, therapy, cognitive behavioral therapy, regardless of what the cause of anxiety is, has been shown to be effective.
And I would like to add that again, to emphasize the heterogeneity in this, something similar to DBS, we have the Duopa, which is a continuous infusion pump. And supposedly that's the best we can get as far as making sure that the dopamine provision at the brain level where we want it is going to be even. So that should fix all of these issues, right? Well, there is a condition called dopamine dysregulation syndrome, or DDS, which is not so much anxiety connected as much as the dysphoria that is sort of the opposite of euphoria, when we are in a very bad mood that can be triggered by the dopamine off states. So people are so afraid and phobic of that state of dysphoria that they would do anything and everything to drive away from it and up-medicate themselves even more than what the prescription says. And it's kind of a counterpart of a drug-seeking behavior for, the narcotics that cause euphoria, and you seek the drug because of looking for the euphoria. This is the flip side of that, where you're phobic of the dysphoria, and that drives you into drug-seeking behavior, trying to avoid the dysphoria. So that's called DDS, or dopamine dysregulation syndrome. You would think that with the Duopa, where you can actually effectively eliminate offs, motor offs that is, this problem will be fixed, and it's not. And so that just speaks to the complexity that some people will have these anxiety or other types of neuropsychiatric phenomena detached from the obvious mechanical dopamine world. And so more work needs to be done. But I think, just like I mentioned earlier, the most important message of this publication is that there is evidence that if you use a good methodology and 200 patients, there is clear and solid evidence that it's not as simple. And practitioners, providers out there in clinics shouldn't dismiss patients whose story just doesn't make sense to them, because it could be a very legitimate situation it doesn't make sense if you have this mechanistical dopamine explanation for everything. And so there are patients who are not typical in that sense, and they still need attention and maybe more attention to help with their anxiety, panic attacks, and other related non-motor symptoms.
You given voice to that which people have had a difficult time expressing or being heard, maybe by their, healthcare providers. So thank you for this work, because this is just so helpful, I think, and maybe explaining to their physicians and that what they can articulate, and that it actually is something real. So thank you for that. This is such important work, and I want to thank you for joining us today. I know everyone's enjoyed it, and I know that we've given you a few bits of information in the chat. So if you all want to make sure you save your chat, you can do that by going down to your little chat box where those little 3 buttons are right next to the 3 dots next to the little emojis. Click that and you can save it. And then I want to thank Dr. Mari and Dr. Pontone for such an important conversation. I think we could talk about this a little bit more. I mean, we have a lot of questions that we just didn't get a chance to get to, but I want to thank you for your expertise and your time. And in PMD Alliance style, we want to give you the wave of gratitude. So I want to welcome everybody to turn on your screens if they're not on, and wave to Dr. Mari and Dr. Pontone and thank them so much for their time and expertise today.
Thank you for the invitation. It was definitely our pleasure.
Yeah, thank you for having us.
Thank you. And everyone, hope you have a great rest of your day.
Bye now.
Bye.